Hello, everyone. My name is Xueying Lyu. I'm a student from University of Pennsylvania. I'm going to present my topic on Tau-Neurodegeneration, mismatch reviews, vulnerability, and resilience that may be linked to non-AD pathologies such as late Alzheimer's continuum and non-AD pathophysiology. In Alzheimer's disease, tau tangles is the driving force of neurodegeneration. However, since neurodegeneration is not specific to tau pathology, in our prior work, we think the regional tau to neurodegeneration mismatch may reveal phenotypes with potential vulnerability or resilience. We used cortical thickness measured from T1 MRI to represent neurodegeneration, and fluorotaucifer tracer uptake for measuring tau. And our hypothesis is in the TN relationships, the patients that fit on this TN linear model tend to be relatively pure AD cases, and the patients with greater neurodegeneration than expected for a given level of tau will be the vulnerable phenotypes. They could be associated with comorbid pathologies. And on the other hand, the patients with less atrophy than expected will be the resilient phenotypes. So based on the residuals of TN linear models on 104 bilateral cortical brain regions, we partitioned those amyloid positive individuals into data-driven phenotypes. We obtained 6 distinct clusters with spatial vulnerability and resilience. Particularly, we defined the groups with the largest number of patients and also displaying typical TN relationships in most of the regions as canonical. And the patients, and we also found a vulnerable and a resilient cluster, mainly showing temporal limbic region greater neurodegeneration relative to tau pathology. This present work is built on that prior work. Here we are trying to replicate this approach on a larger cohort, including both amyloid positive and amyloid negative patients on as-needed datasets. And to provide some ex vivo validation, we also replicated this approach using cortical thickness measured from antemortem MRI and regional tau burden measured from histology in 7 available regions from 202 autopsies in the UPenn Brain Bank. In the in vivo as-needed cohort, we again find the cluster mainly differed in the limbic regions when directly compare them to the canonical cluster. It's notable that the patterns are highly similar under the amyloid positive and amyloid negative subgroups, suggesting the mismatch phenotypes are driven by non-AD factors. And both limbic mismatch phenotypes are also reproducible on our ex vivo autopsies. Since TDP-43 pathology in the form of late usually induce brain regions in limbic regions, we predict TDP-43 may play as a role in the limbic mismatch phenotypes. And with that hypothesis, we then studied the association of TDP-43 severities on our ex vivo autopsies. We found the limbic vulnerable cluster showing significantly higher TDP-43 deposition in medial temporal lobe region compared with the canonical cluster for both all the participants and among the amyloid positive subgroups. So this suggests the limbic vulnerable cluster may contain TDP-43 pathology, which may play as a co-pathology, especially among those amyloid positive patients. And on the other hand, the limbic resilient cluster contain the least amount of TDP-43 pathology, although the difference did not reach the significant level relative to the canonical cluster. So it's likely that lacking of TDP pathology may be a resilient factor for patients from the limbic resilient cluster coping with AD pathology. And in conclusion, our findings suggest TN mismatch modeling can detect vulnerability and resilience in limbic regions, which appear to be driven by TDP-43 pathology. And since currently there is no in vivo biomarkers for late, and our approach may have some clinical and therapeutic implications on AD patients with late pathology. Lastly, I want to acknowledge the help that I gained from my advisor, mentor, lab mates, as well as people from Penn Memory Center. And thank you for your attention.